Acute Maxillary Sinusitis. Etiology. Most commonly, it is viral rhinitis which spreads to involve the sinus mucosa. Now, this is followed by bacterial invasion. Diving and swimming in contaminated waters is a common etiologic factor. Other etiologic factors include dental infections, most important source of maxillary sinusitis. The roots of premolar and molar teeth are related to the floor of sinus and may be separated only by a thin layer of mucosal covering. Periapical dental abscess may burst into the sinus, or the root of a tooth during extraction may be pushed into the sinus. In case of oroantral fistula, following tooth extraction, bacteria from oral cavity may enter the maxillary sinus. Trauma. Trauma to the sinus, such as compound fractures, penetrating injuries, or gunshot wounds, may be followed by sinusitis. Clinical features in acute maxillary sinusitis. These depend on number 1, severity of inflammatory process, 2, efficiency of ostium to drain the exudates. Closed ostium sinusitis is of great severity and leads more often to complications. What are the constitutional symptoms? It consists of fever, general malaise, and body ache. These are the result of toxemia. Headache. Now, this is usually confined to forehead and may thus be confused with frontal sinusitis. Pain. It is typically situated over the upper jaw but may be referred to the gums or teeth. For this reason, patients may primarily consult a dentist. Pain is aggravated by stooping, coughing, or chewing. Occasionally, pain is referred to the ipsilateral supraorbital region and thus may simulate frontal sinus infection. Tenderness. Pressure or tapping over the anterior wall of antrum produces pain. Redness and edema of cheek may occur and commonly seen in children. The lower eyelid may become puffy. Redness and edema of the cheek and then nasal discharge. Anterior rhinoscopy or nasal endoscopy shows pus or mucopus in the middle meatus. Mucosa of the middle meatus and turbinate may appear red and swollen. Postnasal discharge. The pus may be seen on upper soft palate on posterior rhinoscopy or nasal endoscopy. These are the sinuses: frontal, ethmoid, maxillary. And when in an acute maxillary sinus disease, there will be mucopus within the antrum, and this is seen radiologically as a fluid level. In an acute maxillary sinus, when there is a running nose, fluid accumulates in the sinus, manifesting as a fluid level in Waters' view. Fluid level, bilateral acute maxillary sinus disease. Treatment. Antimicrobial drugs. Ampicillin and amoxicillin are quite effective and cover a wide range of organisms. Erythromycin or doxycycline or cotrimoxazole are equally effective, but quite often many may be resistant. Now, these can be given to those who are sensitive to penicillin. Beta lactamase producing strains of H. influenza and Catarrhalis may necessitate the use of amoxicillin clavulanic acid or cefuroxime acetyl. Sparfloxacin is also effective and has the advantage of a single daily dose. Nasal decongestant drops, 1% ephedrine or 0.1% xylo or oxymetazoline, are used as nasal drops. or sprays to decongest sinus ostium and encourage drainage. Steam inhalation alone or medicated with menthol or tincture benzoin provides symptomatic relief and encourages sinus drainage. Inhalation should be given 15 to 20 minutes after nasal decongestion. I repeat, inhalation should be given for 15 minutes after nasal decongestion for better penetration. Analgesics. Paracetamol or any other suitable analgesic should be given for relief of pain and headache. Hot fermentation. Local heat to the affected sinus is often soothing and helps in resolution of inflammation. What is a surgical? There is no role for surgical intervention, especially in an acute maxillary sinus disease. Intranasal antrostomy, because it passes through diploic bone, can lead to osteomyelitis. Do not do that. The only permitted surgical procedure in an acute sinus disease is antral lavage, primarily to get an aspirate to send for culture sensitivity. Most cases of acute maxillary sinusitis respond to medical treatment. Lavage is rarely necessary. It is only done when medical treatment has failed, and that too under antibiotic cover. As a consequence of acute maxillary sinusitis, what are the complications? These are: number one, acute maxillary sinusitis may change to subacute or chronic sinusitis. 2. Frontal sinusitis due to obstruction of frontal sinus drainage pathway because of edema. 3. Osteomyelitis of the maxilla or osteitis. 4. Orbital cellulitis. Infection spreads to the orbit because of edema either directly from the roof of maxillary sinus or indirectly after involvement of ethmoid sinusitis. These constitute the various complications of acute maxillary sinus disease.